Good morning. I'd like to thank Professor Ayman Saleh who invited me to be a speaker. This is an important meetings of intervention cardiology conference with the Egyptian Society of Cardiology. My task today, it is about the new guidelines. It's what's new in the ST segment. The guidelines, it's take a whole day, but I choose in 12 minutes what's new in the ST elevation. This is the guidelines. Okay. Regarding the guideline by Stephen James, this is from Sweden. As you know, the task force of the guidelines involving a lot of authors to make these guidelines, 19 authors, 30 reviewers, 1,224 comments and requests. The level of evidence of this ST elevation is about 159 recommendations. Class 1 or Class A about 23%. And the class of recommendations, 159 recommendations, Class 1 of them is 58%. And this is what's new in the guidelines. Number 1 is myocardial infarction with non-obstructive coronary artery disease, which is the new terminology, and the quality indicators, the new chapters. Strategy selections, number 1, the clear definitions of first medical contact, also called FMC. Definition of time 0 to choose reperfusion strategy clock at the time of STEMI. Selection PCI over fibrinolysis when anticipated delay from STEMI diagnosis to wire crossings. Now terminology is called wire crossing, less than 120. The maximum delay from STEMI diagnosis to bolus of fibrinolysis is only 10 minutes. Now it's obsolete to use what's known as door to balloon. It's obsolete from the guidelines. Also the new guidelines, the timing limits, so expanding now from routine opening to an infarct related artery 0 to 12 is class 1, 1248 is class 2, 2A, and then class 3 more than 48 hours. ECG, left and right bundle branch block, can be used for ischemia, and then you can do angiogram. Time to angio after fibrinolysis is 2 to 24 hours, and patient taking anticoagulants in the different chapters. Let's go for this, an important, usually it should be in ER, the total ischemic time. It doesn't differ except in the timing, between the 2017-2014. As you can see, this is the patient delay, EMS delay, system delay. This is called total ischemic time. The EMS delay, patient delay, calling, EMS delay, going either to FMC PCI center or non-PCI. PCI center, in 10 minutes you have an ECG, STEMI diagnosis, primary PCI, this PCI capable hospital, remember this number, 60 minutes for wire crossing. If you go to non-PCI capable hospitals, for this non-PCI, more than 20, give fibrinolysis within 10 minutes with reperfusions. If less than 20, prime PCI, but not 60 minutes, 90. So 60, 90, 10. So STEMI is the time at which ECG of patient with ischemic symptoms interpreted presenting in ST segment elevation. No nowadays door to balloon or door to door. Regarding the left and right bundle, now also this is new. In the presence of symptom, primary PCI in this atypical ECG presentation, bundle branch block, ventricular pacing, hyperacute T, isolated depression, anterior leads, universal ST depressions. In the presence of these, primary PCI strategy, urgent angio PCI indicated. Let's go for this table. Also, this is an important table to remember. The green is class 1. It should be done. Number 1, the radial axis. It's class 1 by matrix. This is the matrix study showing that it is radial better than the femoral. DS versus VS. DS class 1A through examination and comfortable AMI and non-stent. And this evidence of the studies and DS is better than BMS. Complete revasc. I know that Dr. Hisham is going to speak about this in detail, but actually the complete revasc by important trial, PRAMI, DYNAMI, CULPRIT, compare acute, showing that complete revasc in index hospitalizations is better than to leave it, but doing only the infarcted related artery. Thrombus aspiration, look at this. For complete revasc, it was red, but now it's yellow, it's 2A. Thrombus aspiration was 2A, by TAPAS trial, but following the TASTE trial and TOTAL trial, there is no difference between thrombus aspiration and not. So thrombus aspiration is only as bailout procedures. What the meaning of bailout procedures? When you part the wire and still you have a big thrombus, or you put a stent and there's still a thrombus, you can aspirate. It is not routine aspiration of thrombus. Regarding the bibilirudin, there is no difference between unfractionated bibilirudin in both trials, in matrix and heat PPCI. So now it is shifted from class 1A to 2A. Enoxaparin, by Atoll and meta-analysis, you can see it shifted to 2A nowadays in the STEMI procedures. Regarding the early hospital discharge, actually there is small trial observational that there is no trials, so it's shifted. Early, it's better to be 3 to 4 days to early hospital discharge. Also new is one is green. It's routinely before doing oxygenation for all STEMI patients, but nowadays except if the oxygen saturation is less than 90, and this proved in the avoid detox trial that oxygen is not used in patient STEMI except if the saturation is less than 90. And also what's new here is the TNKP TPA have dose intravenous in patient more than 75 years, and this proved in stream trial. For 2A, additional lipid lowering, if the LDL is even 70 or maximum tolerated, this improved in improvement for Fourier trials. Complete revasc during index primary is expert opinion. Also new here is routine use of deferred stenting is class 3, as is proved in Dynamic 3. Here is important table here. Cangrelor, which we don't have nowadays, maybe next year, Cangrelor use have not been given. And this proved in the BAT proved that Cangrelor is have not given for these patients. Switching to potent P2L12 48 hours after lysis is the expert opinion. I know that nowadays it's three trial using ticagrelor. It's an expert opinion. It's not routinely till changing the guidelines. Extending ticagrelor to 36 months, also 3A by Pegasus STEMI 14. Use of polypill to increase adherence in focus. This is also new. What's going now? We have 3 phases now of infarction. Early phase of STEMI from 0, 3 hours, 12 hours. Primary PCI is class 1A. Fibrinolysis if more than 120 minutes, if not accessible to do primary P. But primary PCI is class 1A, up to 12 hours. Then also extended, evolved STEMI from 12 hours, 48 hours, class 1A. Primary PCI in yellow here, from 12, 24, it's not 1A. 2AB, if it's not, but is an asymptomatic stable patients. And look at the end here, is extended more than 48 hours, called recent STEMI. Routine PCI is a criminal to do routine PCI in asymptomatic stable patient in 48 hours. And I'm going to summarize some of the important time targets to remember. Maximum time from first medical contact to ECG diagnosis should be less than 10 minutes. Maximum expected delay from STEMI to primary PCI to known as primary wire crossings to choose primary PCI strategy over fibrinolysis is less than 120. Maximum time from STEMI diagnosis to wire crossing a patient at primary PCI, less than 60. At non-PCI is 90, but maximum time STEMI to wire crossing in transfer patients. So we have transfer 90, capable hospital 60, maximum expecting delay 120 is 2 hours, ECG is 10 minutes. Another 10 minutes if you suspect that this patient will not be primary PCI, give fibrinolysis in 10 minutes. Then two times importance. After a successful thrombolysis, what to do? 2 to 12, 24 hours is what is the duration of the rescue PCI or the successful phase is 60. To measure that the success is 60 to 90 minutes. Prime PCI of infarcted artery is indicated. Stenting over balloon is indicated, is new generation DS. Radial access is recommended. Then we go to this slide. Important that in the STEMI diagnosis, while crossing, we have ECG monitoring. Remember the green here. ECG monitoring, alert cath lab, aspirin, prasugrel or ticagrel, radial access, unfractionated heparin, oxygen. Then here from 90 minutes to 24 hours, high dose of statins, new generation DS. If you have ejection fraction less than 40 or more than 40, it's ejection fraction oral beta blockers, more than 40, less than 40 is ACE inhibitors. Then more than 24 hours is mineralocorticoids, DAPT, aspirin, routine echo. This is the echo 24 hours, and echo also in 6-12 weeks. This is the timing of the echo. Important in the next 2-3 slides, routine revasculations in non-infarcted artery in myocardial infarction with cardiogenic shock is contraindicated, is class 3. Also in patient out of survivor out of hospital cardiac arrest, and ECG constant with STEMI. And this culprit shock in 30 days results in 1 year favor of culprit lesion only. Finally, it is a percutaneous coronary intervention class 3, and routine revascularization of infarct-related artery is class 2A. Regarding the myocardial infarction with non-coronary, you have to divide the diagnosis into myocarditis, coronary microvasculars, obstructions, myocardial disease, pulmonary embolization, oxygen supply demands, and finally you have to have your quality indicator in your centers regarding the performance measures, the outcome measures, base components of quality, and patient-related outcome. And thank you very much.